With us is Jacqueline Murphy. We're so grateful she's here today. She's Jacqueline, but she goes by Jackie. She became a registered nurse in 2009, graduating from Central Arizona College with honors. She graduated from the University of Arizona in 2018 with her doctorate of nursing practice and as a family nurse practitioner. She completed her doctoral dissertation educating the community about advanced care planning and the importance of communicating end-of-life wishes with loved ones. She's passionate about holistic patient care and has been an advocate for further research and treatment of Parkinson's disease, and has obtained a partnership with the Parkinson's Foundation to offer free genetic testing. Jackie, thank you so much for being here today. We appreciate it.
Thank you so much, and I appreciate everybody being patient while we're having a little computer issues. So as we get my PowerPoint up here, let me know when you're ready. All right, so today we're going to talk about the fundamentals of Parkinson's disease. I just want to put out there, I have no disclosures to put out. Okay. All right, go to the next slide. Okay, so the objectives of today is I want to discuss the definition, prevalence, and cause of Parkinson's disease, how the disease is diagnosed, what are the motor and non-motor symptoms, what are the stages of the disease, what current treatments we have, and then additional resources that you may have in your community. Okay, all right, so what is Parkinson's disease? So according to Oxford Dictionary, Parkinson's is a progressive disease of the nervous system marked by tremor, muscular rigidity, and slow, imprecise movement, chiefly affecting middle-aged and elderly people. It is associated with degeneration of what's called the basal ganglia in the brain, and it's a deficiency of the neurotransmitter dopamine. The function of the basal ganglia is to fine-tune those motor movements. They do so by receiving impulses from upcoming movement from what's called the cerebral cortex, which is deep central in your brain, to the primary motor center, which is essentially where the movement comes from. This is which they process, adjust information, and return the information back to the primary motor center so then you can actually move. Without this, voluntary movement such as walking, getting up from bed, getting out of a chair, things like that become altered. The disease was actually named after James Parkinson, as he was the first physician to document and diagnose the disease in patients with the symptoms. And as you can see, he was 1755 to 1824. So this is a disease we've known for quite some time. Next slide. Okay, so how common is it? So PD had been a rare disorder. However, demographically and by the byproducts of industrialization,
We're going to take a message from our sponsors, Alpo and I don't know, Rachel Ray's dog food, because right now we need a puppy break.
Yes, she still snuck in here, so I apologize. I didn't realize she was still hiding underneath the table. All right, so where was I? So essentially it was a rare disorder, but the byproducts of industrialization are now contributing to what we call the impending PD pandemic. A research study revealed the incidence rates are actually higher than the previously estimated. Previous estimates in the United States were about 60,000 diagnoses annually. However, it is now calculated to be about 90,000 per year, which is about 1.5 times higher than previous study in 2019. It does affect approximately 10 million people worldwide. The key findings of that recent study showed Parkinson's incidence increases with age, so greater than 65. The late onset form is the most common type of disease, and the risk of developing this condition actually increases with age because primarily we're living longer, and so the number of people with this disease is expected as we live longer. Parkinson's disease incidence is higher in males and compared to females of all ages. And the rates are actually higher in what's called the Rust Belt, which includes Southern California, southeastern Texas, central Pennsylvania, and Florida. And that's where a lot of the heavy industrial manufacturing has been. Okay, next slide. All right, so what causes it? Well, approximately 15% of people with Parkinson's disease actually have a family history of the disorder. In familial cases of Parkinson's disease, the inheritance pattern differs depending on the gene that is altered. If the LRRK2 or SNCA gene is actually involved, this disorder is inherited in what's called an autosomal dominant pattern, which means one copy of the gene in each cell is sufficient to cause the disorder. In most cases, an infected person has one parent with the condition. If the PARK7, PINK1, or PRKN gene is involved, Parkinson's disease is inherited in what's called an autosomal recessive pattern. This type of inheritance means that the two copies of the gene is in each cell are altered. And most common, the parents of an individual with autosomal recessive Parkinson's each carry a copy of the altered gene, but they don't ever show signs or symptoms of the disease. Research has shown that people who carry small variations in one of over 20 genes are more likely to develop Parkinson's, and that's why the condition can run in families. However, it's not that clear-cut, and we know that not everyone who carries one of these Parkinson's gene variations will go on to develop the actual disease. So other factors must be involved. Genetic alterations modify the risk of developing Parkinson's disease, but the inheritance pattern is usually unknown. Most cases of Parkinson's probably result from a complex interaction of environmental and genetic factors. This includes damage to what's called the olfactory nerve, so that's the nerve that helps you smell. Alterations in the gut microbiome, so the normal bacteria in your stomach. Chemical exposure, oxidative stress, chronic inflammation like from illnesses or autoimmune disorders, and most recently we're finding traumatic brain injury. These cases are classified as sporadic, and they occur in people with no apparent history of the disorder in their family. The cause of these sporadic cases remains unclear. However, there's a lot of evidence that suggests that sustained exposure to certain environmental risks can cause Parkinson's disease. And exposure to certain chemicals or pesticides, such as like Paraquat, DDT, Agent Orange, Roundup, and trichloroethylene, have been associated with increased risk of developing the disease. And many toxic chemicals have actually been banned from some countries. In relation to the traumatic brain injury, it is now considered another environmental factor that has been linked to increasing risk of developing Parkinson's, but other neurodegenerative diseases as well. Primarily from like sports and concussions that we're finally doing stuff about in younger ages. Next slide. Okay, so what happens in the brain? So we don't fully understand how genetic changes can cause Parkinson's or influence the risk of developing the disorder. Many Parkinson's disease symptoms occur when the nerve cells, or what we call neurons, in the substantia nigra, where you can see is deep central within the brain, when it becomes impaired. Normally, these cells produce a chemical messenger called dopamine, which transmits signals from the brain to produce smooth physical movements. But again, when these dopamine-producing neurons are damaged or die, that communication between the brain and the muscle weakens. And eventually the brain becomes unable to control the muscle movement. So dopamine plays an important role in controlling movements as well as emotional responses. And it is vital to maintain a correct balance of the neurotransmitter for both physical and mental well-being. Without the right balance of dopamine, one may experience alterations in mood, sleep, memory, learning, concentration, along with motor control. Alpha-synuclein is a protein that we have found to be abundant in the brain, but is also found in the heart, muscles, as well as the intestines. In the brain, it tends to be concentrated near the tips of those neuron cells, which are responsible for releasing the chemicals between them. This includes dopamine. And the primary function of the protein is still not completely understood. However, when this protein doesn't function properly or it clumps, it limits the ability of the neurotransmitters, such as dopamine, to be utilized correctly. And when there's a large clumping of these proteins, this is what we call Lewy bodies. Next slide. So in this slide, you'll see on the left, that's the alpha-synuclein protein on the neuron, normal neuron on the left. And on the right, you'll see a bunch of the orange spots, and it looks more cloudy. And that essentially is the clogged proteins in that area. And so it makes that neuron not as functionable. Okay. Next slide. So when does the disease actually begin? So we found in quite a few research studies that there are a few key symptoms that can actually occur up to 20 years prior to the first symptom. This includes loss of sense of smell, REM sleep behavior disorder, which means acting out your dreams, kicking, falling out of bed, hitting furniture, and sometimes, unfortunately, your partner. Also includes constipation and depression. In fact, up to 90% of patients with Parkinson's have lost their sense of smell, and 38% of those actually act out their dreams and develop Parkinson's symptoms within 4 years. Those with significant constipation or depression tend to have 3 times higher risk of developing the disease than those that don't. And so as you can see from this graph, the time of the diagnosis is actually considered 0. But this is typically when patients or families actually start to notice the tremor or even the changes in the gait. But a lot of that stuff happens underneath beforehand. Okay, next slide. All right, so how do we diagnose it? So Parkinson's disease is diagnosed primarily by physical exam. There are 3 key motor symptoms that we evaluate, and that is tremor, rigidity, which is stiff muscles, and bradykinesia, which is slow movements. Patients should have 2 out of the 3 symptoms to be diagnosed. When you are first evaluated by your primary care physician or even by a neurologist, it is important to rule out other causes of these 3 symptoms. All 3 of these can actually be caused by other issues, such as medications. They can actually induce tremors, what's called essential tremor or a familial tremor, stroke within the movement center, and other Parkinson's-like diseases like supranuclear palsy or Wilson's disease. Typically, the workup includes an MRI of the brain, and primarily why we're doing that is because we're looking for structural causes, such as a stroke within the movement center that may be contributing to your symptoms. We also look at lab work, as certain mineral deficiencies or excessive minerals can actually contribute to these symptoms. And then some of you may have gone through a DAT scan, and that really looks to determine the loss of the dopamine cells in the movement center, as you can see on the picture on the screen. So on the left, you'll see what we call they're supposed to look like commas. So that is considered normal, but on the right, you can see that orange brightened up area was looking more like a circle as opposed to a comma. And that means that the cells in that area are no longer creating dopamine the way it should. All right, and then most recently, there's a skin biopsy out, which recent studies have found that excessive alpha-synuclein protein that we talked about a few slides ago within the peripheral nervous system, which means your arms and legs, actually correlates with Parkinson's disease, but also could be in relation to multiple system atrophy and Lewy body dementia. I have personally found that having the skin biopsy being beneficial, because I've seen normal DAT scans and a positive skin biopsy, and patients respond to the medication we use for it. And sometimes that is off. You'll have a normal DAT scan earlier in the disease process. It's also not uncommon for your provider to trial one of the medications that we use for Parkinson's, and that's the carbidopa-levodopa. And what we're really trying to identify is, do you get a response? Did your tremor improve? Does your gait improve? Does your slowness improve? Because if it is, that means that the brain is not creating dopamine like it used to. Okay. So what are the symptoms? Next slide, sorry. All right, so primary symptoms that everybody sees is the motor symptoms. So again, we assess for those key symptoms on an exam to diagnose it. Again, the three areas are bradykinesia or slow movement, tremor, and rigidity or stiffening in the muscles. And not every patient has all three of these, but only two are needed to diagnose the disease. Examples of bradykinesia include decreased blinking. So a lot of patients will have dry eyes or vision changes, loss of facial expression, decreased pace or stride in their walking. They lose the arm swing, or they make smaller steps, or their handwriting is even smaller. Tremors are actually most commonly seen in one extremity in the earlier stages, meaning like primarily the arm, and is the most common reason why patients and family members actually seek medical advice. The tremor is typically worse at rest, and that is usually when a loved one will notice it, because the patient will actually be focused on something else and not able to identify that the tremor is happening. The most common tremor in Parkinson's is what we call pill rolling tremor, and that's essentially like you're trying to roll a pill in between your index or your pointer finger and your thumb, and that tremor is pretty common in the disease. The difference is patients can control this tremor if they actually focus on it. However, increased anxiety or stress may make the tremor look worse. Rigidity is usually seen on the same side of the body as the tremor, and it can cause shoulder, hip, or knee pain. In fact, there have been studies that have shown prior to diagnosis, patients have had multiple surgeries on those joints, but don't ever alleviate the pain that they were experiencing, because the problem wasn't really the joint. The problem was the muscles and ligaments and the tendons wearing down the joint. And so they tend to need replacement sooner. Your medical provider may mention cogwheeling on exam, and this is a sensation that we feel when we're passively moving your wrist in a circle or your knee in a circle, and it kind of mimics a cogwheel, so it kind of gets this catching movement. Okay, we can see that pretty much at any joint. Other motor symptoms can be softening of the voice or mumbling that is worsened when fatigued or even at the end of the day. The gait or walking changes such as shuffling of the feet, what we call fascinating gait, and you can kind of see this in the picture on the slide, where essentially the lean starts happening so much where it looks like the patient's body is trying to move faster than the feet can take them. That does put a patient at very high risk of falls. The other thing would be freezing of the gait. So that's that sensation that you're either stuck in the sand or stuck in mud and you really want to move, but you just can't get your feet to move. Dystonia is stiffening of the muscle that causes it to contract involuntarily, and it can cause like repetitive or even twisting movements, and they're most commonly seen in the foot, the toes, the hands, and the fingers. But there are patients that will get what we call cervical dystonia as well, and that's essentially that your muscles in your neck tighten up so much that it turns your head permanently. Next slide. Okay, so these are the non-motor symptoms, and these are things that people don't typically think about when they think of Parkinson's disease. But this disease isn't just movement, it affects the entire body. So many people with Parkinson's, they have good memory and thinking, which we call cognition, and function normally. However, while forgetfulness may occur with normal aging, more serious trouble with attention, thinking, and memory can occur as the disease progresses. Common cognitive problems include difficulty with paying attention or concentrating, planning events like organizing a busy day, following a complicated conversation, or solving complex problems. Difficulty forming thoughts quickly, remembering events or the details without relying on hints or clues to bring that memory back. When the changes are small without a serious effect to your daily life, that's what we call mild cognitive impairment. But when these changes start affecting your day-to-day routines, such as being able to dress yourself and shower and toilet and so on, that's where we get concerned about dementia. The most common mood symptoms that affect Parkinson's patients are depression, anxiety, and apathy. So depression is a state of low mood, sadness, hopelessness, sometimes with feelings of emptiness or guilt. Anxiety is described as feeling nervous, worry, tension, having a lot of unease. And then those patients with anxiety may actually experience fear or panic attacks, which can be troubling. Apathy is a lack of interest or enthusiasm or motivation to do things that you previously enjoyed doing. Another thing that we may see is impulse control disorder, which can come from the disease, but it can also come from one of the side effects as one of the medications we actually use. But we also use this medication in restless legs. So it's kind of deciphering between, is it medication or is it actually what's going on in the brain? But impulse control disorder can be small things like financial management, like spending money you don't have, gambling, sexual behaviors. But if you think about what happens in the brain while we're not making that dopamine anymore, if dopamine isn't being transmitted properly, the other chemicals aren't. And that's usually the serotonin, the norepinephrine, where you're going to get a lot of the mood symptoms from. Sleep problems are also common in early Parkinson's disease, and then as the disease advances, some sleep problems can even start years before the patient has the symptoms. And it may include things like trouble falling asleep, staying asleep, yelling or kicking, screaming in your dreams, such as that REM behavior disorder, excessive daytime fatigue, falling asleep suddenly without meaning to, which is sleep attacks, having to get up more frequently in the middle of the night to use the restroom, restless legs, which is that uncomfortable feeling in your legs when you lay down, but then it gets better when you get up and move. And then also periodic limb movement, which is almost like a jerking sensation in your sleep in your legs or your arms, as well as interrupted breathing during sleep, which is sleep apnea. Other things would be imbalance, frequent falls, being clumsy, disorganized movement. So constantly dropping things, tripping over curbs, rugs, stairs, very common. And this coordination of movement requires multiple parts of the nervous system work together. And if one is damaged, such as in Parkinson's, this type of abnormal movement will start. And as you can see, there are many other non-motor symptoms that occur in Parkinson's. And will you have all these? Not necessarily. Every patient with PD is actually unique, and not every patient looks alike. So this is part of the reason why your treatment plan is individualized, and what may work for you may not work for another Parkinson's patient. And it's important to discuss these symptoms with your medical provider so that they can assist in managing your symptoms and, most importantly, increase quality of life. Okay, next slide. All right, so how are the symptoms monitored? So there's a few things. At each appointment, your provider will be evaluating the severity of your symptoms by exam, but also by report. On our exam, what we're looking for is to see how well the tremor is moving, or how well the tremor is controlled, the slow movement, and if stiffness is controlled. We actually use a specific tool, and it's called the UPDRS, or Unified Parkinson's Disease Rating Scale. And it's really to identify how your response is to medication, disease stability, progression, as well as potential benefit for advanced therapy. It was actually developed in the 1980s, and it goes over various aspects of the disease, which include those non-motor symptoms as well as your motor symptoms. How these affect your daily life, is there complications that come with it, and what is the extent of the disease burden. Okay. It is also used in research as well as clinical setting. Overall, each section that it goes through is scored on a 0 to 4, 0 being no symptoms, 4 being the most extreme, and they're tallied up between each section and gives you an overall score. The first portion of the exam can actually be completed by the patient or the caregiver or together. And this reviews how, again, how the patient is affected by the disease, which includes mentation, behavior, mood. How is it affecting their daily life? For example, sleep problems, daytime sleepiness, ability to dress, etc. The motor examination is actually performed by your medical provider, and it evaluates your speech, facial expression, muscle rigidity, the speed of movement, leg agility, your ability to rise from a chair, your posture, your gait, tremor overall. And then the last part is really, are you having complications from therapy? The most common complication from therapy is what we call dyskinesias. And that is a disabling or painful movement that that is hard to control. It's almost like a writhing restlessness movement that can affect the entire body. Also evaluating the muscle stiffness and if you're having contractions such as those dystonias. I'm going to show you a quick video. Let me see, share my screen here. And just to kind of give you an idea. Of what this looks like and what to expect. Okay. I just want to make sure you can see my screen. Kelly, are you able to see my screen?
Your screen.
Okay, perfect. All right.
Yep.
I just want to make sure. All right. So this is just a small snippet of the motor exam. I'm not going to have you watch the entire thing because this is just one portion.
And I'm assessing the volume of the speech, whether it's too soft, as well as the normal rhythm. If there's a steady monotone, that would be abnormal and give a rating of 1 at least. And then the rest of the ratings are as indicated. The next thing is facial expression. I'm looking at blink rate and spontaneous expression of the face as their normal expression when she talks, and that would be assessed as noted. If she kind of looks like a poker face, that would be rated as 1. If the lips are parted part of the time, that would be a 3. If the lips are parted the entire time and widely spaced, that would be a 4. The next part is arising from the chair, and the instructions are put your arms across your chest, stand up, and if she can do it quickly like that, that's normal. If she has to push up with the arms or rock a few times, then it would be downrated as indicated. The next part would be posture. Turn to the side for us, please. And we're looking for increased flexion at the neck, the shoulders forward, the elbows bent, the hips bent, or the knees bent more. And that's typically asymmetric. In fact, somebody may even be leaning to the side, and then it's rated appropriately. Next, we'll look at gait, and we'll have you walk up and down the line. We usually have somebody walk at least 15 feet. We're looking at the initiation of gait, the steps, go back, the arm swing, and the turning. Normally the shoulders lead the hips on turning, and that's what we're seeing is perfectly fine. Stay right there, and then we'll check postural stability from the side. And the instructions are keep your feet shoulder length apart. And I'm going to jerk you back, step back if you need to. Don't let me knock you over. And then I give a test one like that. Now I'm going to pull you much harder. I have myself set with the wall behind me in case this is a big person. I'll have some support, and then I jerk them back. And if they take 2 or less steps, that would be rated as normal. If they take more than 2 steps but right themselves, that's a 1. And if they would fall unless I catch them, that's a 2, and so on. And the final thing is just body bradykinesia. We're looking at arm swing, spontaneous expression, and normal movement of the body, and that's rated as indicated. Thank you.
Okay, so that was just a small little snippet. There is pretty much for that full exam is probably about 30 minutes. Okay. And usually your provider will have, we like to see how you move off of meds, and that's what we call off time, as well as on meds. So some facilities, or even if you're looking for, see if you would benefit from advanced therapies, you would come in the morning completely off your medication. We do this full exam on you. You take your medication, you hang out for about an hour, and then you come back in, and we essentially do the same thing again. And we're looking to see how well is that medication actually working for you. Okay. All right. Next slide. All right. Perfect. All right. So what are the stages of the disease? So in 1967, Hohen and Yahr defined 5 stages of Parkinson's disease based off the level of clinical disability. Clinicians use it to describe how motor symptoms actually progress in the disease. On this scale, stages 1 and 2 represent early stage, 2 and 3 represent mid stage, 4 and 5 represent advanced stage. So stage 1 is typically there's no physical symptoms of the disease. You go day by, this is usually before you're diagnosed. Stage 1, during this stage, the patient has mild symptoms. They generally don't interfere with daily activities. You can see the tremor and other movements on one side of the body only. And then the changes in the posture and walking and facial expressions will start to occur. Stage 2, the symptoms start getting worse. And that's where the tremor, the rigidity, and the movement symptoms affect both sides of the body, but also can affect the neck as well as the trunk of the body. Walking problems and poor posture may be more apparent. At this stage, the patient's able to live alone, but daily tasks are more difficult and can take longer. Stage 3 is considered mid-stage. This is where loss of balance, such as unsteadiness as you turn corners, or when you're pushed or you're tripped over something, is pretty common to lose the balance. You can't correct yourself, so falls are more common. The motor symptoms continue to worsen, and functionally the person is restricted in their daily activities, but is still capable of leading a pretty independent life. Disability is mild to moderate at this stage. At stage 4, the symptoms are fully developed and severely disabled. May not be able to walk, or maybe still able to walk, but and stand without assistance, but you may need the assistance of like a cane or a walker for safety to keep you from falling. At this point, the patient will need assistance with daily activities, and it's recommended that they don't live alone anymore. Stage 5 is actually the most advanced and unfortunately the most debilitating stage. The stiffness in the legs make it impossible to stand or walk. So the person is usually bedridden or confined to a wheelchair unless aided, and they do need assistance 24 hours. Okay, next stage, or next slide, sorry. All right, so what about the treatment? So there's a lot of information I go on here. I do apologize if I'm going to throw too much at you, but I'm going to kind of go over each type of classification of medication that we use. And then as you can see, I put the name brands up there. A lot of times you're using generic, much cheaper that way. And then I'll kind of go over the side effects of each one. So carbidopa-levodopa, or Sinemet, is the most effective medication for Parkinson's. It was originally developed in the 1960s. The levodopa actually converts to dopamine. However, if this conversion occurs within the bloodstream before the brain can use it, you can experience nausea and vomiting from it. Therefore, levodopa was actually combined with the carbidopa to assist in reducing these side effects and prevent the conversion to dopamine from occurring before it actually gets to the brain. It is best to take this medication 30 minutes before meals or 2 hours after for best effectiveness, and always stay consistent on timing of doses. I typically will write the prescription as 3 times a day with specific timing, but you adjust based off of your normal daily routine. So I write usually 7 a.m., noon, and 5. And again, if for some reason you do get some nausea still on an empty stomach with taking the medication, you can use like a small piece of toast or crackers just to take with it. The biggest thing is you don't want a heavy meal, and you don't want a lot of protein, because the protein will actually interfere with the ability of the medication to absorb appropriately. As the disease progresses, though, the dosage increases, or the frequency of the medication will be necessary. And it was an old theory that if you start the medication too soon, it's gonna advance the disease, but that's not the case. It's the disease advancing, and your body is just needing more of the dopamine to actually function normally. Potential side effects, as stated, was the nausea and vomiting. That's minimal, but it can include drowsiness, changes in your blood pressure, which can cause lightheadedness or dizziness. or even hallucinations. These complications may develop over time, but they also may cause dyskinesias. And that, again, is that uncontrolled writhing or wiggling movement. And patients, even though they have that symptom, and I've had a lot of patients that they need the higher dose of the carbidopa-levodopa to manage their tremors and movement, but they feel better when they're dyskinetic like that, which is difficult to watch as a family member or even a provider here. But the other thing would be increased off time. So that's when the symptoms return before your next dose is due. So there's a lot of medications coming out on the market essentially to help prevent that off time or lengthen the carbidopa-levodopa out so it's more effective. The next class is dopamine agonists. This type of medication actually stimulates the area of the brain that's influenced by dopamine. So the brain is actually tricked into thinking that it's still receiving or making enough dopamine. It can be taken with or without the carbidopa-levodopa. And compared to levodopa, long-term use of dopamine agonists may be less likely to lead to those dyskinesias or off times. And if these symptoms do develop, they may be less severe. The common side effects of those, again, nausea, low blood pressure. They can also cause leg swelling, drowsiness, those sleep attacks, hallucinations. And in some people, these drugs can actually lead to impulse control disorders, as stated before, the compulsive gambling, the hypersexuality, excessive shopping. Next, we have the COMT inhibitors. They're actually used in conjunction with carbidopa-levodopa to assist in prolonging the effects of the medication. This classification actually blocks an enzyme in your body that breaks down the levodopa, and this allows more of it to actually get to your brain to be converted into dopamine. COMT inhibitors are not effective on their own, and they must be combined with the carbidopa-levodopa. And this drug does help with the wearing off symptoms or helps prolong the effects of the carbidopa-levodopa. Common side effects include diarrhea, urine discoloration, and the taucapone can actually cause liver damage. So typically what we do prior to starting would be assess the liver function and then routine monitoring. All right, so adenosine receptor antagonist is another add-on therapy to carbidopa-levodopa. This classification actually blocks the chemical adenosine in the brain, which boosts the signaling of dopamine, and it's used to help treat those off times. And this one's a once-a-day dosing. Common side effects include the dyskinesias, dizziness, constipation, nausea, hallucinations, and insomnia. All right, so anticholinergics, they can be helpful with the tremors and dystonia, but they have very little benefit with the other symptoms of Parkinson's. These medications decrease the activity of acetylcholine that regulates movement. Anticholinergics can be used alone or taken with any of the other therapies, and they typically work best to treat the tremor, especially in younger people. They sometimes are prescribed for dystonia, that prolonged muscle contraction, and sometimes it is used to treat drooling that can come with the disease. Side effects include blurred vision, dry eyes, dry mouth, constipation, cognitive problems, hallucinations. And because older people are more susceptible to side effects, these drugs are typically used in patients that are younger than 70. All right, so monoamine oxidase type B is actually an enzyme in your body that breaks down several chemicals in the brain, including dopamine. By giving you a medication that blocks the effect of MAOB, or monoamine oxidase type B, there should be more dopamine available in your brain to use. This can modestly improve your motor symptoms, but it can also provide some benefit for just managing the motor symptoms as an early therapy prior to starting carbidopa-levodopa. When used with the other medications, it may reduce off time and extend the on time of the carbidopa-levodopa. This classification has been used in patients in earlier stages and are also used in patients that wish to delay the use of carbidopa-levodopa. And in some people, certain MAOB inhibitors can lessen fatigue and even depression, although antidepressant effects usually come at higher doses when they're prescribed in Parkinson's. Side effects of these include flu-like symptoms, joint pain, and blood pressure changes. Selagine may actually cause insomnia or hallucinations, both of which are more likely to occur in older people or the advanced stages. I will tell you from recent experience in the last year or so, racesagiline is probably the most commonly prescribed medication in this classification, but insurances are dropping it as on the formularies, and unfortunately it's become pretty expensive. The other options I have found in my experience tend to have more of the side effects that come with it. And the concern is when you're taking this medication, we've got to be cautious on, or closely monitoring when you're taking it with antidepressants or muscle relaxers and some herbal supplements, because it can actually give you a rare disorder called serotonin syndrome, which can cause worsening muscle stiffness, increased tremor, increased heart rate, blood pressure, and agitation with confusion, and it is actually a medical emergency. At high doses, or even when combined with foods that contain tyramine, like cheeses or cured meats, it can actually elevate your blood pressure. All right. Amantadine works on the dopamine and the glutamate brain chemical pathways that can treat the slowness or the bradykinesia, the stiffness or rigidity, as well as the tremor, but is also used to treat dyskinesias when patients have higher doses of therapy or require more frequency of dosing, or just the higher doses itself, where you end up getting the dyskinesias, but you feel better on it. This will kind of counteract the dyskinesias. Can notice a decrease in fatigue, particularly with the immediate release, but there is an extended release that tends to be more beneficial, but both of them can actually cause insomnia. And the other most common side effects would be nausea, dizziness, and red blotchy spots to the skin. There are times where hallucinations, dizziness, dry mouth, swelling the legs and feet can actually occur too. All right, so the last one is decarboxylase inhibitor. This prevents the body from converting levodopa to dopamine. So more levodopa can actually get to the brain and convert it to dopamine there. The carbidopa also helps prevent or lessen levodopa side effects, such as the nausea and vomiting. So a lot of times, this will be prescribed by itself in addition to your, as a separate pill in addition to your carbidopa-levodopa mix, so that you get less of the nausea with it. It does come in a pill form, but it also comes in a gel form now, which I'll go over in a few slides here. Most common side effects would be nausea or vomiting. And again, can be used to ease the side effects of other medications. Get out. Take them out of here. As you can see, pretty much all of these medications seem to have a common side effect of hallucinations, which can be pretty disheartening, because there's a fine line between, having hallucinations specifically from the disease, but also have them worsen from medications as itself. Okay, next slide. All right, so advanced therapy. It's not something to consider at the early stages of the disease, but I do believe it's important for you and your family to know about these therapies if needed in the future. So deep brain stimulation, or DBS, that's actually a type of brain surgery that assists in treatment management for tremors and dystonia. In DBS, a thin insulated wire called an electrode is actually placed deep in the brain. The electrode is connected to a pacemaker-like device that's placed under the skin and the chest. It sends electrical signals to the implant, from the implant site to the brain to control the symptoms. The advantage of this therapy is it doesn't cause permanent brain damage except for the tiny region where the electrode is placed. Instead, electrical impulses modify brain activity. And the leads can be placed on both sides of the brain depending on your symptoms, and your medical provider will determine best location and if both electrodes are needed to be placed at the same time. Currently, there are 3 companies that make deep brain stimulation. That's Medtronic, Boston Scientific, and Abbott. Deciding on which company to use is multifactorial and should be discussed with your provider what best device to go with based on your individual needs. They all have their pros and cons. Also thalamotomy. So this is a procedure that Michael J. Fox actually had in 1998. This involves a thin wire temporarily placed within the thalamus, deep central in the brain, and the tip of the wire is heated to burn a small piece of the tissue within the thalamus, and then the wire is removed. This will reduce the abnormal brain activity and calm the tremors only. It doesn't affect any of the other symptoms from the disease. Unlike deep brain stimulation, this procedure can only be performed on one side of the brain. And if you've had this procedure, unfortunately, it kind of minimizes your ability to get further advanced therapies like the DBS. And this procedure is not used as often as DBS is anymore. And I do have a video I want to show you on this one too. Let's see. All right, this one's, it's always pretty cool to see when we turn on deep brain stimulation, how much benefit it does provide the patients. Okay.
Okay, so we're here for the initial programming session. You got both sides of the brain put in, bilateral stimulators, and we're here for the initial programming session. This is what it looks like without the medicine and the stimulator. And now we're just going to turn it on. If I can get my fat fingers to hit the button, there we go. See how that feels. How you feel? A lot better. Yeah. Excellent. Try tapping both your fingers for me. Excellent. All right. Feels pretty good? Oh, yeah. Okay, good. Excellent.
Yeah, so had a lot of Parkinson's patients that have had implants, and it definitely is life-changing, not having to rely on the medications as much. Okay, next slide. So a few other advanced therapies. Gamma knife surgery is uses a radiation beam to actually burn that small piece of tissue in the same area as the thalamotomy, but it doesn't require the invasively accessing the brain like the previous procedures do. This procedure is only used if patients are not a candidate for deep brain stimulation though. Focused ultrasound is similar to gamma knife, however, it uses ultrasound instead of radiation. And honestly, I personally haven't had anybody that's had either one of those procedures for Parkinson's. All right, so Duopa, this is that gel-like dopamine, sort of carbidopa form that I was telling you about in the other treatment slide. So this uses a combination of carbidopa, levodopa, and that gel form that's actually delivered directly into the intestines by a pump for up to 16 hours a day. The Duopa actually bypasses the stomach and delivers a continuous infusion of the carbidopa levodopa into the duodenum, which is the small intestine, which often reduces or eliminates the fluctuations that patients experience with just regular carbidopa levodopa. With Duopa, a procedure is required to make a small hole called a stoma in the wall of the stomach to place a PEG J tube for delivery of the carbidopa levodopa suspension. The PEG essentially means a percutaneous endoscopic gastrostomy, and the J is the jejunal. The PEG J tube is connected to a cassette that actually contains the Duopa and a pump, and then it, which actually pumps that the Duopa into the intestine, which I have seen has been pretty beneficial in patients as well. All right, next slide. Okay, so supportive therapy. Now, maintaining a healthy diet is actually beneficial for the entire population. However, there are certain foods that have been found to be more beneficial in supporting healthy living. And one of the specific diets that has received most attention is the Mediterranean diet, which is characterized by high intake of plant foods, vegetables, fruits, legumes, whole grains, slow to moderate intake of fish and wine, and other components like phenolics, fibers that actually exert antioxidant or anti-inflammatory effects. These elements have been associated with favorable gut microbiome and balance out the good bacteria in your stomach. Research continues to evaluate diet and disease process further, but and many diseases have shown reduced risk by just making this one change. If able, organic or non-GMO foods are best, as they meet specific standards to have less synthetic pesticides or chemicals. And as I stated before, we know that Roundup, Agent Orange, and other pesticides and herbicides that we've used in farming can be found in some of those foods. Interestingly, greater consumption of dairy foods such as milk or cheese has actually been associated with higher risk of Parkinson's. This was observed in all dairy foods, including low-fat milk, and then don't really understand the underlying mechanisms for that. Hydration. It seems like a silly thing to even bring up, but people who with PD drink half as much fluids as people without due to the lack of thirst sensation. The medication side effects or even trouble swallowing can be a problem with hydration. Medication and the effects of Parkinson's can actually contribute to loss of interest in food. And some medication can cause nausea, which can make it difficult for patients to actively remember to stay hydrated, especially if that means increasing the water consumption. And then many of those patients may be more concerned about decreasing their water intake because they're urinating so frequently at night, but then it's almost like a catch-22. Parkinson's patients can experience the depression because of these symptoms you're experiencing. You're losing that interest in food and drink, and most effectively can affect your overall mood. Okay, supplements. Because Parkinson's patients generally experience what we call oxidative stress, several studies have actually examined dietary antioxidants such as vitamin E, vitamin C, carotenoids in relation to Parkinson's disease risk. There isn't clear evidence to support the protective effects of the dietary components on Parkinson's, but in contrast, they have found dietary flavonoids were inversely associated with Parkinson's disease. The risk. Consistently, consumption of these type of foods, such as berries and fruits, actually were associated with lower Parkinson's risk. And there are a few studies that are out there that actually show that coffee, so regular caffeinated coffee, is neuroprotective. It also not only protects the brain, but also helps with the constipation and all the fatigue that can come with Parkinson's. Okay, next slide. Okay, so keep moving. So exercise is an important part of healthy living for everyone, but for those with Parkinson's disease, exercise is more than just staying healthy. It's a vital component to maintaining balance, mobility, and activities of daily living. Research shows that exercise and physical activity can not only maintain balance and improve mobility, flexibility, but it can also ease the non-motor symptoms such as depression or constipation. To help manage your PD symptoms, aerobic activities, strength training, balance, agility, and multitasking and flexibility can improve motor and non-motor symptoms. There are many exercise programs for Parkinson's patients, and PMD Alliance has many options available on their website, which include online and in-person groups listed by state. I've listed a few here. Rocksteady is actually a nonprofit organization that provides non-contact boxing to help combat the physical and motor symptoms of Parkinson's, but also helps improve muscle endurance, hand-eye coordination, speed, and most importantly, balance. LSVT, or Lee Silverman Voice Treatment Global, was developed to help Parkinson's patients improve speech and later on added movement, which is now known as LSVT Big and Loud Therapy. They train speech, physical, and occupational therapists these treatments to help those within the community. And personally, as a medical provider, I advise my less active patients to plan on me referring them at least on an annual basis to be trained by these therapists, because it does help retrain yourself on how to actually walk and speak and with your balance, because you're not able to recognize those changes in yourself. PWR, or Parkinson's Wellness Recovery, offers exercise classes in person and online, and they also have a week-long retreat for Parkinson's patients and caregivers on an annual basis. Dance for PD actually brings dance and creativity to Parkinson's patients. It was actually a research idea that started in New York City and is now a global Parkinson's therapy. They found that dance helps increase strength, flexibility, balance, and stamina, all of which can be a challenge for those with Parkinson's. Classes are available in person and online, and I have personally experienced this program at the PMD Alliance All-In Conference this last October, and it was pretty awesome to see so many Parkinson's patients and their loved ones dancing and just having fun. Yoga for Parkinson's offers online yoga courses for patients with Parkinson's, but it also trains yoga instructors on how to incorporate this therapy for Parkinson's patients. Yoga has been shown to help improve mobility, balance, and movement, along with focusing on mindfulness, which can help improve overall mood. And there are many exercises and groups that are available to assist you along your journey, not only to help you with your physical symptoms, but surrounding yourself with other Parkinson's patients can help you through your own journey. Okay, next slide. All right, but most importantly, get involved. You are not alone in this disease. There are so many resources out there for you. Whether it's a support group, in person, online, an exercise group, participating in research, it is all good for your mental and physical health in this disease. Enjoy life. I know this may sound hard, but be open about the disease to your friends and families. And again, you're not in this alone. Continue to do the hobbies, travel, do the things you previously enjoyed doing that brought life before you got this diagnosis. Minimize stress as much as you can, and stay healthy. And the more that you can support your immune system, the better off you're going to feel longer. Become active in your treatment. Very important. Ask questions, educate yourself. There are so many resources available to you, whether it's through PMD Alliance, the Parkinson's Foundation, Michael J. Fox Foundation, books, whether on paper and audio. There's so much out there. The foundations that I've listed and societies I've listed here are just a handful of the support that is out there for you and your family. There are many state and local Parkinson's group, and many of them are actually listed on the PMD Alliance's website. Also, if you or your family needs financial assistance with medication or other services, there are many of these foundations actually have that support. Okay, next slide. Okay, and then lastly, very important, become involved in research. You know, even if it's just doing the PPMI study that Michael J. Fox Foundation is doing, I'm personally a part of it as somebody that doesn't have Parkinson's disease. They're really tracking symptoms in patients with and without Parkinson's over the trajectory or time frame to see if we can further get a better picture of the disease and hopefully help at some point find a cure for it. So these are just a couple of the websites I'd recommend just taking a peek at. They will list any of the research centers close to you if you're interested in doing that. Okay, next slide. And that is it. I gave you a ton of information. I know you're going to have a lot of questions, so I guess we'll open up to that.
This was awesome, Jackie. Thank you so much. I got so much out of it. We did have a few questions. Part of it was a lot of people were curious about the skin biopsy because I think on some level it seemed at least something concrete. I know a patient once said to me, it seems like voodoo medicine, the way you get diagnosed, that they're like, go like this, walk down a hall, and yes, you've got Parkinson's. So I feel like, because I know that obviously the DAT scan doesn't really use that. Can you tell me a little bit more about the biopsy? And then someone also asked if Medicare covers it.
Yeah, actually Medicare does. So yeah, it's considered a punch biopsy. So I haven't had a Medicare denying coverage on it. And even the commercial ones, I haven't had an issue with that. So yeah, I mean, that's the challenging part, because we've had just medications and the DAT scan for all this time. And the DAT scan I've seen in patients that have had a stroke in the area come back positive for Parkinson's, but really, able to piece out those things that, 100% you're not being able to identify that. So yeah, the skin biopsy actually has won some international awards from the Movement Disorder Society International, to help essentially diagnose sooner. I've even had patients that, God forbid, had very minimal symptoms that just did not make sense. And DAT scans were negative, but they responded to the medication. And so we did the skin biopsy, and lo and behold, that protein is severely abundant in the peripheral nervous system. So they're actually, right now, they are able to identify, with that protein being the peripheral nervous system, identify, is it Parkinson's, multiple system atrophy, or Lewy body, which all three can look alike. They just progress a little bit differently. So difference between Lewy body and, say, Parkinson's, Lewy body dementia, you'll have a lot of mood fluctuations, hallucinations, REM behavior, and cognitive problems prior to the tremors, the slow movements, gait problems, where Parkinson's disease is the opposite. Okay. Multiple system atrophy is a little bit different. Again, it can look like Parkinson's disease, except for these patients tend to have what we call a pure autonomic failure. So the autonomic system really isn't functioning anymore. So a lot of fluctuations in heart rate and blood pressure, and sleep problems and breathing. It affects everything. So they're still doing some studies to kind of pinpoint, the positive sites from the skin biopsy, and how does that correlate with just Parkinson's disease? How does that correlate with just multiple system atrophy, and so on to Lewy body dementia? So there's still research going on, but it does give answers. I will tell you, I've had quite a few patients, again, quite a few vets, unfortunately, that they were just labeled as PTSD patients. And we did this and fixed all their meds, because they were on so many meds that are so bad in one of these disorders, and gave them their life back. I mean, it was life-changing. So ask your provider. It's not happening everywhere quite yet. I know I brought this up to PMD Alliance about a year and a half ago, because I was such a big advocate for it, and Georgetown University is now supporting it as well, and they're actually doing the skin biopsies there too. So it is becoming more widespread. Just start asking, and if you can't get the answer somewhere and you want to do that test, CND Life Sciences is the lab, and they can help find a center that has the ability to do the test for you.
Thank you. We did have also a couple of questions about, is there any connection between alcohol abuse and Parkinson's, or is it affected by even small amounts, or modest drinking might affect the onset or progression of it?
I don't think we have a clear-cut answer on that, but I will tell you, if long-standing history, chronic alcoholism, can affect balance and shrink a certain sort of area of the brain that is affected in Parkinson's disease as well. I don't think there's a direct correlation between it, to be honest with you. But having what we call a neurodegenerative disease, meaning a disease that shrinks the brain faster than what we'd expect for your age, anytime you have any type of insults that may affect the brain to be able to process appropriately, when you have that underneath, is going to make it worse.
Also had a question about akathisia, feeling like you're going to jump out of your skin. Could you kind of talk a little bit more about that?
More of
I guess
being startled?
Somebody just said it was about feeling like he was going to be jumping out of his skin. And so I wasn't sure if that was actually not something I'd really heard about. I wasn't sure if maybe that was something that can be treated or with any of the medications.
Honestly, I have not heard that from many of my patients. So I can't really answer that question, but I'd be more than willing to look into it and get you an answer, and you guys can notify the participants if you'd like.
Perfect. I will do that. And then, because obviously this has been in the news lately, can you talk a little bit about the wearable devices that use electrical stimulation or vibration, like the gloves that are now in trial?
Excellent question. Sorry, I didn't mention that. I completely forgot about putting that in there. So I actually did help do a little bit of a study with Boston Scientific and one of these watch devices a couple years ago. And, you know, when we see the patients in the office, we're only getting the snippet of how well you're doing on your medication. So it is a challenge because you are taking the medication 3 times a day. And these devices can help remind you to stay consistent on your dosing. That's a good one thing. But the other thing I found when reviewing the data that they had provided is that we can really target the roller coaster ride that happens with carbidopa levodopa. So we can see the peaks and then the valleys and then the peaks and then the valleys. So really it helps us fine tune the therapy so that we can reduce that amount of fluctuations in the symptoms. I think they're still doing more research on it. I know when I was doing the study with them, it was just evaluating the daytime symptoms and wasn't doing for nighttime, because a lot of stuff does happen through the night, and how off are you when you wake up in the morning. So there is more stuff coming out there, but definitely, I mean, it at the least side of it, if it helps you remember to take your medication on time consistently, it is definitely worth it. And then devices specifically to reduce tremors, like the weighted gloves or weighted bracelets, those are always beneficial. Yeah, it's not going to be 100% where it's correcting underneath, but if you can utilize these non-pharmaceutical treatments without having to rely on so much medications, you know, you may feel better for a longer period of time.
You did talk about some precursors, for example, like REM behavior disorder and constipation. Someone asked, is there any correlation with like trigger finger or carpal tunnel, or correlation with Parkinson's and Epstein-Barr, or pretty much just what you discussed?
No. So there is the research. So the oxidative stress and the inflammatory response can come from any infection. I've seen, you know, some of my patients that had Epstein-Barr. Pretty much everybody's had Epstein-Barr. So where that data, that research is coming is kind of hard. It's their suspicion, but they don't have the supportive evidence as of yet. But valley fever, COVID, 100%. I've seen new onset coming out of that. So pretty much anything that causes an inflammatory response in the immune system to be hyperactive can essentially cause it to cause long-term effects on the brain. And we've seen that with COVID. I mean, we originally thought that it came out as just a respiratory disease, and lo and behold, it's affecting the entire nervous system. And yeah, I mean, I still think that's going to be where things are going to be at in the next 20 years as people get older with having the disease, or the virus, I should say. So yeah, I mean, there's even some studies that say chemotherapy or cancer or whatever, but there's not enough supportive evidence to directly correlate with it.
And so now I just want to ask a little bit about, so we got diagnosed. What do you suggest as far as, you know, obviously you'd probably want everyone to go see a movement disorder specialist if possible, or, you know, like you've been trained for this as an advanced practice provider. You would encourage exercise, you would talk about the diet. What are some things you could really just kind of say, you know, hey, it's not that, because people also want to know about progression, but obviously there's no crystal ball. So, you know, like what would you say? Like you got this diagnosis, now what?
I would say do your own research, because educate yourself as much as you can. And yes, seeing a movement disorder specialist is beneficial because they'll have additional resources in the community that maybe your local neurologist or primary care physician does not have. A lot of those centers do have physical therapy, as well as speech therapy and social workers and dietitians that all work underneath one roof. So those type of centers are helpful. You get everything in one place. The downfall is that these centers for excellence are usually in a large city somewhere, and can be a challenge getting there, especially if you live in a rural area, or if it's 2 or 3 hours away. Then you're kind of relying on, what's around you. But even if you just got a consultation and you saw, them once a year, and then your general neurologist manages everything else in between, I think that is beneficial too. But yeah, I've downloaded, just because this again is something I'm passionate about. When I'm working out or I'm driving in the car for a long way, I'm listening to Parkinson's books on Audible, and what the research is doing, and how certain patients have adapted, or little tricks that they've had. So there's a ton of stuff out there for sure. And don't be afraid to ask questions either.
Exactly. That's huge.
Yes.
And also when you say, when people go to their doctors, what do you advise? Because obviously, I'm sure you heard this a lot, where someone will say, you'll say, how are you doing? And they'll say, fine. And then you're kind of like, oh, I guess we're done here. Like what do they need to prepare for their appointments?
I would say if you're having a weird symptom, don't be afraid to ask it, because even, so neuropathy is common in Parkinson's disease. So there's a lot of other things that can come with that. Erectile dysfunction is common in it. The drool. So some of these things that are taboo to talk about, you should bring up, because if it's happening underneath and it's really affecting your quality of life, make sure you're having it addressed. And sometimes it's hard to remember exactly what your questions are, or what you're going to ask, or how you've been feeling. Write it all down, bring it in with you, and definitely ask questions. If you're not able to get your answers from that, then there are additional resources within the community that can help you walk through some of those underlying concerns to help you navigate it, I guess. But yeah, definitely bring up pretty much every symptom you may have, because it's probably all related, unfortunately.
Get request if you could talk a little bit more about the weighted devices and how they can help.
Mm-hmm. So weighted devices, so they have weighted bracelets, they have weighted gloves. Now these are primarily going to help for tremors, because essentially, I don't know if anybody has tried this, but if you're writing and you've got this tremor that's going on, even if you just put a small little pressure on your wrist, you can get better control of the tremor. So that's where these devices are helpful. It gives that sense of weight there, so you can get better control. But the other thing would be weighted pens. I've seen weighted paintbrushes, weighted colored pencils, all of cups, knives, spoons, plates. There's plenty of them. Amazon has everything now. So just type in weighted for Parkinson's and you will get a ton of things listed available.
Now I have someone asked if you could please discuss ropinirole and the CUE system. So I guess my first question is going to be, what is the CUE system? And then what is ropinirole's effect on it?
Wow, okay. Yeah, excellent question. I don't CUE system. I don't have an answer. That might be something I need to come back to. Yeah, put it on my list.
Okay, I can respond back to that.
Okay.
Somebody did say that they also have the, I thought this was funny, that aphasia. I call it, I have that jump out of my skin. I call it the princess and the pea. So I thought that was pretty funny. I'm like, you gotta have your sense of humor in all of this.
Yeah. Like, I mean, some of that could all be relation to what we call small fiber nerves not functioning properly, small fiber neuropathy. So that's a lot of the sensory nerves, the temperature, touch, pain, sensation, those can all be affected. And sorry, going back to the skin biopsy, it does look at the small fiber nerves, as well as a couple other things, but there is correlation between that type of neuropathy and Parkinson's.
And then, does anybody else have any other questions? Because otherwise I can just talk and I can ask all my questions that I have. So if you guys have some questions you'd like, you did a great job with the overview of the medications and everything.
It was a lot though. So hopefully some of it sticks. A lot of information. So hopefully you learned something from it.
The nurse practitioner I used to work with, she would say that often what she did like was to have lower doses but various medications. And she would say, a lot of times people would say, I'm already taking, so many meds, I don't want to do that. But she said that it was almost like, her analogy was that it was like a lamp. And it's like, if a lamp is broken, you're going to check the light bulb, you're going to check the wiring of the lamp, you're going to see if the lamp is plugged in. And that was sort of how she looked at it. It was like all the different medications can complement each other.
Exactly. So, a lot of those that are additive to the carbidopa, levodopa, they help booster it so it is more effective, blocks other things that breaks it down so then it's more effective. So don't just think that your provider is just trying to throw more meds at you. I hate that. I am not one that likes to just throw meds at everything. I want to make sure that it's a conversation between me and my patients on, what is the best option? What routes can we go? What is really causing you most distress and how do we fix that? And then, sometimes just even adding even like the dopamine agonist, adding that in there may help with, the restless legs as well as the sleep and multiple things as opposed to just movement in itself. Get more bang for your buck from a combination.
Do you have any specific?
Go ahead.
No. I was just going to ask, do you have any other, also some like you mentioned yoga? I mean, are you sort of like, do you have a favorite or are you just sort of like, look, I just want you to move. I want you to stay active. I want you to, it's like, if you want to yoga, if you want to, punch in Xerox Steady Boxing, if you just want to go on a treadmill.
I think it's what interests you, because if you're not somebody that likes to go to the gym because it's monotony and you don't know how to go through that process, get in something that, other people are involved with and make it, building relationships as well. And, honestly, I mean, anything that makes you want to move and be more active makes me happy. But I would say here in Arizona, I know out here in the East Valley, Banner Neuroscience has a facility that is pretty much like a gym for Parkinson's patients, which is pretty cool. So they have speech, physical, and occupational therapists there. They have the support groups that meet there. So they have all the boxing, the yoga. I mean, all these exercise programs all in one place within the community. It is, unfortunately, they don't take insurance. So it's kind of like a gym fee, right? So there's the pros and cons of that too. But something where you can try multiple types of things and find what interests you and what you would like to pursue doing. I mean, heck, even Zumba would be a good thing to do.
I'm sure enjoying it also.
No, exactly.
We did have a question. What causes a full head or a fuzzy head?
Yeah, it's the cognitive fog. So it's not uncommon. Sometimes it's the medications, but sometimes it's in relation to the sleep pattern, underlying untreated sleep apnea most certainly can cause that. But really, the electricity in the brain or the communication between those specific chemicals really aren't as effective as they used to. And that's where you can get that cognitive fog or that brain fog, and makes it difficult to concentrate and think. And so there's a lot of tricks you can try with that. It's unfortunately, it's going to be trial and error on specific types of medications to help with it or eliminating medications.
there any help for the startle movement when awake and jerking when asleep?
So the jerking when asleep, if we're talking periodic limb movement disorder, that is helpful, or even the REM behavior. Melatonin is actually one of the best things available for REM behavior, but the jerking and the sleep can be in relation to other things. There are some medications that can cause what we call nocturnal myoclonus, where you just get this jumping movement. So really going through the medications that you're currently taking with a fine-tooth comb and eliminating those that can contribute to that. So I will tell you, Cymbalta is a great drug. We use it for migraines, fibromyalgia, depression, sleep issues, but it causes that. So, you know, and it usually doesn't come out right away. It can be years down the road. So you may not even think it could be in relation to the medication in itself. But, you know, if it's straight up periodic limb movement disorder or restless leg syndrome or acting out your dreams, melatonin is helpful, 10 milligrams a night. It's not to initiate sleep, it's to initiate the area of the brain that is no longer paralyzed while you're sleeping because of where the Parkinson's is affecting it. And it helps regulate that again. The only other thing that we have on the market, which, you know, is DEA is very restrictive on, is using things like clonazepam or pralazam at bedtime to essentially suppress that area of the brain. It works, but, you know, you could get long-term effects from that too.
You did kind of talk about the choking. What happens when you've got the trouble swallowing or you're choking on pills and food, but the tests are coming back okay, that there's not a blockage, there's not?
Yeah. So I've had this experience with the patient previously, where she always had that sense that there was something in her throat or she was swallowing glass. It's after doing all the workup, the swallow test was good. The GI study looking at the esophagus was good. Ear, nose, and throat. Went and looked down at the larynx. That was good. I have found a few case studies, and it seems to be more of a neuropathy of what's called the glossopharyngeal nerve. So it gives that sensation that you're having the problem. There are some medications that are helpful for it. But the flip side to that is that I tell my patients, remember this disease affects every single muscle in your body, and your larynx and esophagus is a muscle. So there are times where that starts to be affected, and sometimes that in itself can respond to increasing on your carbidopa levodopa. Sometimes it doesn't, but the other thing would be doing the big and loud therapy. So the loud therapy is projecting your voice and using that larynx box, so you're strengthening the muscles up and going from there. But, you know, the challenge is down the road is that swallowing can be a problem, and that's where we keep a close eye on that with speech therapists. And if necessary down the road, you may need changes in, you know, the texture of your foods or the thickness of your liquids, or even they use Botox for what we call dystonia of the larynx. So it's just the muscle so tight, so the Botox will actually relax that, so you have that normal function again.
Well, we are out of time. This was incredible. We learned so much. This will be available. If you'd like to save your chat for some of the links, we encourage you to, in your chat that I hope is open, you click on the little 3 dots, more will appear, and then it will prompt you to save your chat. So I do encourage you to do that. Jackie, thank you so much for giving us your time. As always, we have our tradition at PMD Alliance, our wave of gratitude. And we thank you so much. I hope everybody has a wonderful rest of the day.
Thank you for everybody's time. Have a good night.